Hello and welcome back to Immunology, the War is Over, the Clinical Conditions. In this episode, we'll be exploring Paroxysmal Nocturnal Haemoglobinuria, or PNH for short. PNH is a condition in which intravascular hemolysis leads to anemia and ischemia, and in some, it carries a risk of life-threatening thromboembolic disease. Now, thankfully, PNH is rare, but you and I both know that even when something is rare, if it has the potential to kill you or cause organ damage, then there's a good chance it'll show up in your exams. So let's become acquainted with PNH. In this tutorial, we're going to cover what causes PNH, the clinical manifestations of PNH, and how we diagnose and treat this condition. So first up, what causes PNH? In PNH, the key problem is hemolysis, specifically intravascular hemolysis, where the destruction of red cells is happening right there in the circulation in real time, as opposed to extravascular hemolysis, which is when the red cells are broken down in the spleen. As you might imagine, red cells being broken down in the circulation will cause a lot more havoc than red cells being broken down in the spleen. And this intravascular hemolysis in PNH leads to all of the clinical manifestations of this condition, and we'll be discussing these in just a tick. The mechanism of hemolysis in PNH is related to the destruction of red cells by complement. Healthy red cells have potent complement regulators on their surface, CD55 and CD59. These simply do not tolerate complement landing on the red cell surface. It's sort of like when you're sitting outside on a beautiful sunny day, enjoying your surrounds, and then a mosquito lands on your arm. Chances are you will swat away that mosquito swiftly and without hesitation. And this is exactly how CD55 and CD59 respond to complement on the red cell. Whenever complement tries to get comfortable, it will be batted away in a jiffy. But in order for CD55 and CD59 to be there on the cell surface, they require an anchoring molecule. And this anchoring molecule is known as GPI. I'm not even going to try and pronounce the actual name of that molecule. It's pretty much unpronounceable, but I will write it down just in case you're interested. So these GPI anchors are absolutely necessary for CD55 and CD59 to be there on the red cell surface. Without these anchors, the complement regulators will be missing, leaving the red cell very vulnerable to destruction by complement. And this is exactly what is happening in PNH. In PNH, there is a genetic mutation in the PNH gene which codes for these GPI anchors. This renders the anchor deficient or defective, and so any molecules on the cell surface which depend on this anchor to be there will either be deficient or absent. So in PNH, there's no problem with the complement regulators themselves, it's just that there's a difficulty placing these regulators on the cell surface without that anchoring protein. And it's important to acknowledge that this genetic mutation in the PNH gene is not something that these patients were born with. Rather, it's an acquired genetic mutation which happens spontaneously in that person's lifetime. And it only happens in the bone marrow. And so the PNH mutation isn't part of the person's global DNA. It doesn't affect every cell in their body. It's only happening inside the bone marrow, and so will only cause problems with hematological cells. And so if you can imagine all those little cell lines in the bone marrow at various stages of development, just dividing into their relevant lineages, doing their thing. Then, all of a sudden, out of nowhere, one of those cells that's very early in the production line decides to chuck in, albeit accidentally, a PNH mutation. This changes everything. Now, every cell that originates from that mutated cell will now be affected by the PNH mutation. So this mutation is carried by all the cells which come after that original mutated cell. And as you can see, this means that lots of different cell lines are affected, not just the red cells, but the white cells too. And this is an important concept which we use to diagnose the condition. When we test for PNH in the lab, we actually test a few different cell lines, not just the red cells. And we'll come back to this again when we come on to discuss the diagnosis of PNH. So the PNH mutation happens early in the bone marrow production line and creates a population of affected cells of different lineages. And equally, there are many cells which did not originate from the mutated cell line, and these cells will be entirely normal. So in PNH, there's a population of abnormal cells and a population of healthy blood cells. So in someone with PNH, it's not like every single red cell is going to crumble at the hands of complement, but there will be a population of red cells that are vulnerable to this. And so the severity of PNH will be determined by the amount of abnormal blood cells, as well as the severity of the genetic mutation, and whether this leads to just a deficiency or a complete absence of complement regulators on the cell surface. So just to recap, PNH happens when there is an acquired genetic mutation in the PEG-A gene at an early point in the bone marrow production line. The abnormal cells that arise from this will have trouble placing GPI-anchored proteins on their surface. Such proteins include complement regulators, CD55 and CD59, and without these, red cells are extremely vulnerable to hemolysis at the hands of complement. And we said before that intravascular hemolysis is where all the clinical manifestations of this condition originate. So now let's take a look at how PNH shows up in clinical practice. Perhaps the most confusing part of PNH is the fact that they named it PNH in the first place. The paroxysmal nocturnal name doesn't really reflect the 24/7 nature of this condition. But it is paroxysmal in the sense that things will be worse when complement is particularly active, say during an infection. Broadly speaking, the clinical manifestations of PNH can be categorized into symptoms which result from anemia, transient ischemia, or thromboembolic disease. It's a no-brainer when a condition involves hemolysis that you're going to see anemia and the symptoms which accompany anemia, such as breathlessness and fatigue. And in fact, fatigue is by far the most common symptom experienced by this group. But there's also a constellation of symptoms which may occur secondary to transient ischemia, and this is far less intuitive. When hemolysis occurs in the intravascular space, free hemoglobin is released into the circulation. This mops up and steals away nitric oxide and reduces the availability of nitric oxide to surrounding tissues such as smooth muscle. Nitric oxide normally relaxes smooth muscle and promotes vasodilation. And so without nitric oxide, blood vessels will constrict, leading to transient ischemia. Symptoms vary depending on which vascular bed is affected, but typically symptoms arise from cardiovascular, neurological, or gastrointestinal involvement. And whilst transient ischemia is problematic, the most dreaded complication of PNH is thromboembolic disease. This can be lethal. And whilst not everyone with PNH will develop a clot, it's the most concerning feature of this condition. Hematologists in this field have described PNH as the most vicious acquired thrombophilic state known in medicine. Now that's quite a statement, and so it follows that someone's tendency to clot or not to clot will have a significant influence on management decisions. Thromboembolic complications of PNH for the most part affect the venous system, but arterial clots can occur. And even within the venous system, clots may appear in unusual places, such as the cerebral, intra-abdominal, or hepatic veins, leading to things like Budd-Chiari syndrome. The pathogenesis of these clots is not fully understood, but it's thought to be a multifactorial interplay between complement and the coagulation cascades, various inflammatory mediators, as well as the impact of low nitric oxide, which can influence our fibrinolytic system or clot breakdown system. Interestingly, clotting isn't necessarily prevented in PNH by anticoagulation. Alternatively, they can be minimised by using complement inhibitor. So PNH presentations are non-specific. Symptoms and signs will depend on which particular vascular bed is affected by hemolysis, transient ischemia, and or thromboembolic events. And so we have this rare, potentially life-threatening condition with a non-specific presentation. And that really puts our diagnostic skills to the test. Perhaps the first challenge is just knowing when to think about PNH in the first place. So when should we think about PNH? Helpfully, some clever haematology folks got together and created some guidelines which answer this very question. And the good news is that there are only 3 scenarios in which we must consider PNH. Scenario number 1. Hemolytic anemia with no apparent cause. Clues to hemolysis include low haptoglobin, high LDH, elevated bilirubin, and hemoglobinuria. And when we come across hemolysis, the next thing we want to do is look at the blood film. In PNH, the blood film is entirely normal. There are literally no clues on the blood film. So provided they don't have something else like iron deficiency, the red cells should look entirely normal under the microscope. So the normal blood film in and of itself is a clue. The other test we do in hemolysis is the Coombs test. This checks for the presence of autoantibodies stuck to red cells. And we know that PNH has nothing to do with autoimmunity, and so the Coombs test is negative. So if you come across a scenario where you have hemolytic anemia with a normal blood film and a negative Coombs test, you should think about PNH. Scenario number 2, hemolysis with unexplained cytopenias or bone marrow disorders. This one makes a lot of sense. If someone has a bone marrow disorder, it's a ripe environment for an acquired mutation to thrive. We said before that PEG-A mutations tend to happen within one production line, which means we have all of the other production lines which are healthy and making completely normal cells. These healthy cell lines tend to compensate for issues within the PNH cell line. So you could have a PEG-A mutation that causes no harm at all because the number of healthy red cells is much higher than the number of abnormal red cells. But in the scenario where you have a bone marrow disorder, you already have a lower number of healthy blood cells, which means that the impact of a PEG-A mutation would be amplified. Some bone marrow disorders which are typically associated with PNH include aplastic anemia and myelodysplastic syndrome. Thankfully, when PNH accompanies these disorders, it tends to be mild, and so these patients are far more likely to be troubled with cytopenias than hemolysis. But nevertheless, PNH can occur. So if someone has unexplained cytopenias or a formally diagnosed bone marrow disorder and they have hemolysis, we need to think about PNH. And lastly, scenario number 3, unexplained thrombosis. I think it's fair to say that most doctors have a healthy discomfort with unexplained blood clots and are likely to seek the expert opinion of our trusty haematology colleagues whenever we see one. But just so you know, an unexplained clot, especially in an unusual place like the cerebral or intra-abdominal veins, or if a clot happens when someone is anticoagulated, we need to do a hemolysis screen and consider the possibility of PNH. And so we see a pattern emerge. We need to think of PNH whenever there is an unexplained hematological situation. Unexplained hemolysis, unexplained cytopenia with a dash of hemolysis, or unexplained thrombosis, particularly when that thrombosis is located in an unusual place or when it occurs despite being anticoagulated. So that's when to think about PNH, but how do you actually clinch the diagnosis? The answer is flow cytometry. This is the gold standard test for diagnosing PNH. Flow cytometry is basically a fancy way of saying we're going to put these cells through a machine which can tell us which molecules are present or absent on the cell surface. Haematologists use this all the time to characterise and quantify the populations of blood cells in various conditions. But in PNH, the surface markers of interest are those GPI-anchored proteins. So for red cells, these are CD55 and CD59. But if you think about it, in PNH, a lot of those abnormal red cells will already have hemolyzed and have been removed from the circulation. So it can be tricky to actually detect the abnormal cells. So we get around this by looking at the white cells. These too are affected by the PEG-A mutation and will have deficiencies of GPI-anchored proteins on their surface, such as CD24 in granulocytes and CD14 on monocytes. So we pass both the red cells and the white cells through the flow cytometry machine to see if we have a population of cells which do not express these GPI-anchored proteins on their surface. And to make a diagnosis of PNH, there must be a deficiency of GPI-anchored proteins in at least 2 different cell lines. Isn't that fascinating? Who knew? Something very important to point out here though, is that not everyone who has a PNH clone on flow cytometry has PNH, because PNH clones can be present in healthy people too. So just having a few abnormal cells here and there doesn't necessarily equate to clinically relevant disease. But if you did find a PNH clone, you'd want to monitor that person from time to time to make sure that the cell numbers weren't climbing and putting that person at risk. So that's the test for PNH, flow cytometry. But some of you might be wondering, is there any role for bone marrow aspirate in this condition? And this is a great question, but the answer is no. The bone marrow contains cells at various stages of development. As these cells mature, they gain more and more surface markers. So in the bone marrow, not every cell is going to have all of the surface markers that would be associated with a fully mature blood cell. But when these cells do reach maturity and leave the bone marrow, they have all of the surface markers that they will ever have on their surface. And so it follows that the way to diagnose PNH is to perform flow cytometry on peripheral blood, which contains all of those mature blood cells. So unless you're looking for an underlying bone marrow disorder, bone marrow aspiration is not necessary for the diagnosis of PNH. And what about genetic testing for PNH? We said before that this is an acquired mutation which occurs in the bone marrow, and so technically you could do some genetic testing of blood cells and find this mutation. But again, just having the mutation doesn't necessarily translate into clinically significant disease. And because it's an acquired mutation, it's not going to be passed on to that person's offspring, so you don't need genetic counselling and family trees or anything like that. So genetic testing for PNH can be done for research purposes, but it's not very meaningful in clinical practice. And now that we're able to diagnose it, it begs the question, how do we treat this condition? For mild disease, the mainstay is supportive therapy like folic acid and iron supplementation, as well as blood transfusions when needed. And in these milder cases, thromboembolic complications may be reduced by using aspirin and avoiding thrombogenic medications such as the oral contraceptive pill. But for patients on the more severe end of the spectrum, and to facilitate safe pregnancy, definitive treatment may be indicated. In theory, this condition can be cured with a bone marrow transplant. But bone marrow transplants come with their own significant morbidity and mortality, which can be much worse than PNH itself. And so, unless someone needs a bone marrow transplant for another condition, we don't tend to perform these solely for the treatment of PNH. Instead, when needed, we reach for eculizumab. Eculizumab is a C5 inhibitor which blocks the terminal pathway of complement. When it binds to C5, it prevents this from being converted into C5a, a potent anaphylatoxin, and C5b, the first building block of the membrane attack complex. And so eculizumab protects the red cells from destruction by complement. Overall, eculizumab reduces the morbidity associated with PNH, prevents life-threatening complications, and enables healthy pregnancies for patients with this condition. So even since writing the script for this tutorial on PNH, there's been a major development. There's actually a new drug that's become available for the treatment of PNH, and in Australia this has become PBS approved. Where it used to be that we only had eculizumab, and eculizumab wasn't funded by the prescribing authority, now there's a new drug called ravulizumab, which is PBS approved. It works in the exact same way as eculizumab, so it's also a C5 inhibitor and it's a monoclonal antibody. The only difference is that ravulizumab lasts longer, so it's given every 8 weeks as opposed to every 2 weeks like eculizumab. So still very, very, very expensive, but PBS approved now. And so for PNH in Australia and perhaps in other countries around the world, you're likely to see people on ravulizumab as opposed to eculizumab. Breaking news. Now back to the tutorial. The other downside of eculizumab, apart from the cost, is the increased risk of meningococcal infection. Before starting this treatment, patients must be fully vaccinated against meningococcus. And because we don't have vaccinations against every single meningococcal strain out there, we also typically manage these patients with long-term amoxicillin prophylaxis as well. So that's PNH in a nutshell, a pesky little haematological condition entangled with the complement cascade. Thank you so much for joining me, and I hope to see you again soon for some more high-yield learning. Bye!